Hello everyone and welcome to our module on primary amenorrhea. Amenorrhea refers to the absence of menses, and it can be divided into two forms, primary and secondary. In primary amenorrhea, an individual never begins menstruating despite reaching the normal age of puberty. The formal definition is a failure to menstruate by age 15 with normal secondary sexual characteristics, and secondary sexual characteristics are things like breast growth and a female fat distribution. An alternative definition is no menses by age 13 with an absence of secondary sexual characteristics. And then secondary amenorrhea refers to a situation where menses begin but then they stop. So a woman has had menarche, she's begun to menstruate, but menstruation stops. That's secondary amenorrhea. And so in this video we're going to focus on primary amenorrhea. So let me give you a way that you can think about all the different causes of primary amenorrhea. So in order for menses to begin, first of all, the pituitary gland has to work. So if there's something wrong with the pituitary gland and it doesn't release FSH and LH, then menstruation won't occur normally. And so in a minute we'll talk about a number of causes related to the pituitary gland and the release of the gonadotropins, and these things can lead to primary amenorrhea. You can also have primary amenorrhea if the ovaries don't work. So for menses to occur, the ovaries have to release estrogen. If they don't release estrogen, then menses won't occur, and that will lead to primary amenorrhea. Now importantly, when the ovaries are the problem in primary amenorrhea and they aren't releasing estrogen, FSH and LH levels will be very high. That's because the pituitary gland is responding to the low estrogen by releasing more gonadotropins. And we'll also talk in a few slides about various ovarian disorders that lead to primary amenorrhea. You can also have primary amenorrhea if there's an anatomic problem. If there's an absence of the vagina or the uterus, then menstruation isn't going to occur normally. And then lastly, the trickiest causes are hormonal disorders. There are some rare congenital disorders where the body is unable to either synthesize or respond to hormones, and this leads to amenorrhea, and we'll talk about these as well in this video. And then lastly, you always have to remember that even in girls who have primary amenorrhea, you always have to rule out pregnancy. This is always a potential cause of amenorrhea, whether primary or secondary. Let's start by talking about pituitary disorders that can cause primary amenorrhea. So remember that the hypothalamus releases GnRH onto the pituitary, which triggers the pituitary to release LH and FSH. If there's anything wrong with this process, that can lead to primary amenorrhea. Whenever the cause of primary amenorrhea is a decrease in the release of LH and FSH from the pituitary, this is called central hypogonadism. And it's called this because the cause is central to the body within the pituitary gland. So some of the important causes of central hypogonadism are shown in this slide. In a minute we'll talk about functional hypothalamic amenorrhea. We'll also talk about constitutional delay of puberty and GnRH deficiency. In hyperprolactinemia due to any cause, there will be amenorrhea. That's because prolactin suppresses the release of the gonadotropins from the pituitary. So one of the things that has to be considered in any girl who has primary amenorrhea and has not begun to menstruate is that you need to check her prolactin level to rule out that she might have hyperprolactinemia. There are also some rare tumors of the central nervous system that can impact the pituitary gland. For example, a craniopharyngioma can do this. So also part of the workup for primary amenorrhea is often an MRI, and that's because an MRI can evaluate for tumors that might be affecting the anterior pituitary so that it cannot release LH and FSH. Functional hypothalamic amenorrhea commonly causes secondary amenorrhea, but it can also cause primary amenorrhea. In this condition, there's decreased release of GnRH from the hypothalamus. There's also low levels of estradiol in the plasma. There are also low or low normal levels of LH and FSH. Basically, in this condition, the entire hypothalamic pituitary gonadal axis is suppressed, so that the release of everything from GnRH to LH and FSH to estradiol is decreased. And this all comes together to cause amenorrhea. And this condition usually develops when the body is under significant stress. So usually there's some obvious risk factor for why the body is being stressed, leading to functional hypothalamic amenorrhea. This could be an eating disorder, this could be excessive exercise or weight loss, this could be heavy stress. But in women who develop any of these factors, they often stop menstruating. Many times this is a woman who's already had menarche, so it's secondary amenorrhea, but sometimes it also happens in girls who have not yet had menarche, and in those cases it causes primary amenorrhea. Constitutional delay of puberty is the most common cause of delayed puberty. It's caused by a temporary defect in GnRH release from the hypothalamus. And the word temporary is important because this condition usually resolves with the passage of time and doesn't require any intervention. It's more common in boys, but when it occurs in girls, it can lead to delayed menarche and primary amenorrhea. And it often runs in families with late bloomers, so a boy or a girl who has constitutional delay of puberty will have parents who also had puberty onset at a very late age. As I said, this condition usually resolves with the passage of time, so normal puberty eventually will occur, but at a later age. And so patients with this condition are going to present with the delayed onset of puberty, and when that happens, usually the test that is ordered to confirm a diagnosis of constitutional delay is a bone age determination. To determine the bone age for a child, you obtain an X-ray of the left hand and wrist, and then that X-ray is compared to population norms in terms of what's expected for bone growth, and from this you can determine a bone age for the child. And this is a useful test in children who have abnormal growth, whether they're not growing in terms of height or they're not entering puberty as they should. If the bone age is less than the chronologic age, this is what you see in constitutional delay of growth in puberty. Children with a bone age less than chronologic age should eventually grow and enter puberty. So for example, if the child is 15 but the bone age is 12 or 13, that indicates a child with constitutional delay. Eventually that child should grow and enter puberty if they have not yet. On the other hand, if the bone age is identical to the chronologic age, then if you're evaluating a child for short stature, this tells you that the child is going to have familial short stature. These are children who will ultimately have a relatively short height, and they usually come from families that also have a short height. If you're working a child up for delayed puberty and the bone age matches the chronologic age, then that means the diagnosis is not constitutional delay, and you have to look for some other cause for why the child has not yet entered puberty. And then another cause of central hypogonadism that can lead to primary amenorrhea is GnRH deficiency. If the hypothalamus does not release sufficient GnRH, then puberty and menarche won't develop normally. This is also called idiopathic hypogonadotropic hypogonadism, which is just a fancy name for having low levels of LH and FSH. This is also called Kallmann syndrome when it occurs together with anosmia and loss of smell. And usually this is a genetic inherited syndrome. There are many forms that have been described, including autosomal dominant, autosomal recessive, and X-linked forms. It's much more common in males, but when it occurs in females, it can lead to primary amenorrhea, and it's very difficult to distinguish a GnRH deficiency from constitutional delay. Often these children are presumed to have constitutional delay, and only when they don't later have a growth spurt and enter puberty is it determined that they more likely have a GnRH deficiency. Okay, so now let's move on from talking about the pituitary gland and central causes of primary amenorrhea, and let's talk about ovarian disorders that can lead to primary amenorrhea. So in order for menstruation to occur, the ovaries have to produce estrogen and progesterone, and so if the ovaries have failed for any reason, then these hormones won't be produced and menarche and menstruation won't occur. In girls, one of the most common reasons for this to occur is Turner syndrome. Girls with Turner syndrome are usually 45X0, meaning they are missing an X chromosome, although there are some other variants. And girls with Turner syndrome do not have normal ovaries, and they don't produce estrogen and progesterone, and that leads to primary amenorrhea. You can also see ovarian failure in girls who have received chemotherapy or radiation for childhood malignancies. But in all of these situations, the ovaries have failed, so the estrogen levels are going to be low, and the levels of FSH and LH are going to be high because the pituitary works, and it's going to release lots of gonadotropins to try and drive the ovaries to make estrogen, but the ovaries aren't working, so the estrogen doesn't get produced. Okay, so back to this slide, we talked about pituitary disorders that can cause primary amenorrhea and ovarian disorders. Now we're going to talk about some anatomic disorders that can lead to primary amenorrhea. Let's start by talking about Mullerian agenesis, which refers to underdevelopment of the Mullerian system. During embryologic development, the Mullerian system is what goes on to form the uterus and the cervix and other elements of the internal female genitalia. So if this doesn't develop normally, then a girl will be born without a uterus, and therefore she's obviously not going to have menarche and menstruation. In babies born with Mullerian agenesis, the external genitalia can appear normal, but usually there's no cervix or uterus, and there's an absent or shortened vaginal canal. Often there's just a small pouch or dimple at the vaginal opening. This is an example of what it can look like here on the screen. So girls with Mullerian agenesis will obviously have primary amenorrhea because they don't have a uterus and an endometrial lining to lead to menstruation. The ovaries, however, are functional and normal in girls with Mullerian agenesis. So they will enter puberty and have normal secondary sexual characteristics, things like breasts and pubic hair, and they will have normal hormone levels on serum testing. The diagnosis is made by pelvic ultrasound. It will show ovaries with no uterus or cervix, and that's how you know that the girl has Müllerian agenesis. And so part of the standard workup for primary amenorrhea is to order a pelvic ultrasound to confirm that the girl has a uterus. And it's high yield for your boards to know that Müllerian agenesis is associated with renal and urinary abnormalities. So renal ultrasound is almost always done when you identify a girl with Müllerian agenesis to make sure that her kidneys and ureters are normal. And so Müllerian agenesis is an anatomic abnormality of the upper genital tract, meaning the uterus, but there can be lower genital tract lesions as well that can lead to primary amenorrhea. An imperforate hymen is when there's a sealed membrane over the vaginal opening. This can present with amenorrhea and pelvic pain because the woman isn't able to menstruate normally. Tissue accumulates behind the hymen. Sometimes on exam you can see a bulging obstruction to the vagina if a girl has primary amenorrhea and symptoms from an imperforate hymen. And then another lower genital tract lesion is a transverse vaginal septum. This is where a wall of tissue develops crossing the vagina. This also presents as amenorrhea and pelvic pain because the tissue from menstruation backs up behind the obstruction, and this is also usually diagnosed by a pelvic examination. So going back to this slide once again, we've talked about pituitary and ovarian causes of primary amenorrhea. We've also discussed anatomic disorders. We'll finish this video by talking about hormonal disorders. These are the most confusing set of causes of primary amenorrhea. This is where there's a problem producing or responding to sex hormones, and that leads to amenorrhea. So there are two important hormonal causes of primary amenorrhea. In both of these conditions, the individual is XY and should have developed as a male, but has female appearance because of abnormal synthesis or response to hormones. Because the individual is XY, there are no ovaries present to cause the menstrual cycle, and this is going to lead to primary amenorrhea. And so the two disorders in this category are androgen insensitivity and 5-alpha reductase deficiency. The complete androgen insensitivity syndrome is caused by a mutation in the androgen receptor that occurs in XY individuals. So in this disorder, the androgen receptor is abnormal, and these individuals can't respond to androgens. So even though they are XY and should develop as males, they have a female appearance because they're unable to respond to androgens. So in someone with CAIS, the testes form in utero. That's because there is a Y chromosome, so the testes will form, and there are no ovaries. But because there's no cellular response to androgens because of a mutated receptor, the individual will have a female external appearance. There will be no internal or external male genital development, and that's because the cells cannot respond to androgens. And in addition to having no internal or external male genitalia, there will also be no internal female genitalia. That's because the testes contain Sertoli cells, and they release Müllerian inhibiting hormone, and this leads to degeneration of Müllerian structures, so there won't be a uterus or fallopian tubes. So individuals with the complete androgen insensitivity syndrome have a female appearance at birth. They do not have external male genitalia despite having XY chromosomes. They have testes, but the testes don't descend, they're in the abdomen, and so this will appear to be a female individual until the time of puberty. When that happens, there will be primary amenorrhea, and that's because there is no uterus present to lead to menstruation. Also at puberty, the testes will begin making more testosterone. This won't lead to armpit or pubic hair because this requires androgen effects, but it will lead to breast development because some of the testosterone is converted into estrogens. So what this is going to look like, and the picture of this you have to have in your mind to answer board questions about it, is it's going to be a presumed female who has breast development at puberty but isn't menstruating and has very little or no armpit or pubic hair. And just like we talked about earlier, the pelvic ultrasound is a very helpful test in the evaluation of primary amenorrhea. In the complete androgen insensitivity syndrome, it will show absence of a uterus, and that's because there is no uterus because it is an XY individual. And the diagnosis can be made by doing a karyotype, which identifies the chromosomes. It will show an X and a Y chromosome, like in this example on the screen here. And you can also measure a testosterone level, and this will be high because the body is making lots of testosterone, but the individual is unable to respond and generate testosterone effects. So this is a very rare disorder, but the classic case you want to know for your board exams will be a child with primary amenorrhea who does have breast development, but there's little or no pubic or axillary hair. On examination, there's a blind vagina and you don't find a cervix or a uterus, and on ultrasound you see absence of a uterus or a cervix. And then, as I said in the last slide, you can confirm the diagnosis with a karyotype and a testosterone level. And then one other high-yield fact about complete androgen insensitivity syndrome is that the testes are removed at puberty. That's because if they're left in the abdomen, there's a chance that they will develop into a malignancy, so they're always surgically removed. The other important hormonal cause of primary amenorrhea is a 5-alpha reductase deficiency. This is an autosomal recessive disorder where babies are born lacking the enzyme 5-alpha reductase, which is necessary to convert testosterone into the very potent androgen dihydrotestosterone, or DHT. So babies born with this condition who are 46XY can make testosterone, but they have an impaired ability to make DHT. And DHT is very important during development. It's responsible for formation of the external male genitals. So these babies will be born without normal external male genitalia. Often they appear to be female at birth. There are testes present because there's a Y chromosome. The location of the testes is variable. They can be intra-abdominal. Sometimes they descend and are in the inguinal canal or in other locations. And then at puberty, testosterone is going to be produced because there are testes present. And this is going to lead to the development of male features at puberty, but sometimes this occurs in what was apparently a female at birth because of the absence of external male genitals. So in a case of 5-alpha reductase deficiency, there's normal internal male genitalia because development of the internal male genitalia does not depend on dihydrotestosterone. So these individuals have a normal epididymis, vas deferens, and seminal vesicles. Externally, however, you really need DHT for formation of the external male genitalia. So in a 5-alpha reductase deficiency, there's an absence of external male genitalia. Often it appears predominantly female, although there's a range of female genitalia that can be seen. Sometimes it appears to be ambiguous. Sometimes it appears to be entirely female. The vagina is blind ending. That's because there is no cervix and there is no uterus. So just like with CIAS, in many cases, an individual with 5-alpha reductase deficiency can appear to be female at birth until the time of puberty, when puberty does not occur normally. And that's because, even though it appears to be a female, the individual has XY chromosomes. What's going to happen at puberty to this individual who appears to be female is there's going to be masculinization. There'll be more testosterone produced, and this will lead to muscle growth. There's usually some dihydrotestosterone production, not the normal amount, but when you have lots of testosterone, you inevitably get some DHT. And so the testosterone and the DHT lead to hirsutism and deepening of the voice, and there can be growth of the phallus so that the genitalia start to appear more male at the time of puberty. And just like with CAIS, the diagnosis is made through a karyotype plus a testosterone level. The karyotype will show XY chromosomes, so you know that this is an XY individual. There will be normal male levels of testosterone, and then there will be a high ratio of testosterone to DHT, and that's because of the absence of this enzyme, so that the levels of DHT are very low. And once again, this is a very rare disorder, but in terms of answering board questions, you should know that masculinization at puberty is very important for distinguishing a 5-alpha reductase case from CAIS. In a person with CIAS, at puberty there's breast development like we talked about earlier. In a person with a 5-alpha reductase deficiency, there's masculinization at puberty, and this is one way, especially in board questions, that you can tell these two disorders apart. I'll finish with this one slide from the White Coat Companion, which shows all the elements of the workup of primary amenorrhea. So I can't emphasize enough how important the pelvic ultrasound is. If there's no uterus, then you're dealing with most likely either Müllerian agenesis or some hormone problem. In this situation, the next best test is the karyotype and testosterone level, as we have been discussing. If the patient is 46XX with female testosterone levels, then most likely that's a case of Müllerian agenesis. If, on the other hand, it's a 46XY individual with male testosterone levels, then you're dealing with androgen insensitivity or 5-alpha reductase deficiency. And we were just talking on the last slide about how you can tell these two disorders apart. If, on the other hand, the uterus is present, then the next test you want to do is an FSH level. If the FSH level is high, then that means the ovaries are failing for some reason. And as we discussed, a common reason for this to happen is Turner syndrome, and that can be diagnosed by a karyotype. If the FSH level is decreased or normal, however, then you want to evaluate for secondary sex characteristics. If you have a normal FSH level and normal secondary sex characteristics, then that could indicate an anatomic problem like imperforate hymen or vaginal septum. If, on the other hand, there are no secondary sex characteristics and the FSH level is low, then what you may be dealing with is a case of central hypogonadism, where you have low FSH and also low estradiol coming from the ovaries. So in that scenario, you want to think about things like GnRH deficiency, constitutional delay, or hypothalamic amenorrhea, all these things we talked about earlier in this video. And that concludes our module on primary amenorrhea.